Assalamu alaikum wa rahmatullahi wa barakatuh. Our subject today is systemic lupus erythematosus, or I will continue to call it SLE for short. What is systemic lupus erythematosus? To start with, we should know a few things about SLE. It is a chronic inflammatory condition. This is the first to be put in mind. It's a chronic disease. Number two, it is a multisystemic disease that virtually affects every organ in the body. And number three, it is an autoimmune disease. When we say autoimmune disease, we need to know two things. Number one, in the pathophysiology, there should be antibody reacting to an antigen. This is number one. Number two, the course of all autoimmune disease is a slowly progressive type that continue to get worse over time, but from time to time there will be an acute worsening, which we call it exacerbation. So the course of all autoimmune disease characterized by exacerbation remission course. Now, systemic lupus erythematosus or SLE is a disease of young age female, with female to male ratio is 9:1, and the peak age of incidence is between 20 to 30 years. The disease is more common and more severe in African population and in Southeast Asian population. How disease occur, or what is the pathophysiology underlying SLE? There are several theories to explain the pathophysiology. One of them is that the normally dying cell in the body by apoptosis is abnormally handled by the immune system, meaning when cell die, there will be exposure of the underlying nuclear substance of that cell, which is recognized by the immune system as antigenic substance. It is abnormal substance, and the immune system will react to that substance by activation of the immune system, activation of T lymphocyte and B lymphocyte, with production of antibodies. Now, this is supported by the fact that environmental factors that causing exacerbation of SLE, such as UV light, citrus, infection, increasing oxidative stress, all increase apoptosis. So, apoptosis, which is normally occur, just abnormally handled by the immune system. How patients with SLE present? Majority of patients has non-specific symptoms, such as fatigue, malaise, anorexia, sometimes weight loss, and even low-grade fever. But as we mentioned previously, it is a multisystemic disease. So we will go in each system in detail, starting with skin manifestation of the disease or mucocutaneous manifestation. Number one is butterfly rash, which occur in 20% of the SLE population. It is an erythematous raised rash that usually occur over the cheek and the bridge of the nose, characteristically sparing the nasolabial fold. Now, this rash could be painful, could be itchy, and is usually worsening on sun exposure and does not fade on pressure, and indicate active disease. Usually occur during active disease. Is acute rash that disappear when the disease remits. Number two, photosensitive rash that occur in sun exposed area like the arm, neck, face. It consists of erythematous lesions, often with fine scale. On remission, it may leave both inflammatory changes, but this rash does not cause skin atrophy or loss of skin appendages like hair or sweating gland. Third type of rash is a chronic type called discoid. As the name applies, is disc-like, rounded lesion. Occur in 20% of patients with SLE, so it is uncommon. 1/5 of the patient has discoid rash, but what is more important, discoid lupus can occur as isolated lesion in patients who will not develop SLE in the future. It is usually affecting the face, scalp, and presented as hypo or hyperpigmented lesion, possibly erythematous. What is most important is a chronic disfiguring lesion cause destruction of all skin appendages and alopecia when involving the scalp. Next, skin and mucocutaneous manifestation is ulcers, mucous membrane ulcer, which could be occur in the oral mucosa or nasal mucosa, occur in 5% of SLE patients, and it's usually painless. Rhinoid phenomena occur in 60% of the patients. Next system is a musculoskeletal manifestation. Patients usually presented with arthralgia and early morning stiffness. Arthralgia means pain in the joint, but without sign of inflammation, only pain. This is the most common musculoskeletal manifestation, arthralgia. Less commonly, the patient presented with arthritis, meaning the patient has pain, swelling, redness, and tenderness of the joint. So it is an inflammatory joint disease, arthritis, but less common than arthralgia. Characteristic of this arthritis in patients with SLE is usually polyarticular, symmetrical fashion, peripheral, and usually migratory arthritis. What is the difference between arthritis of rheumatoid arthritis and SLE? SLE does not cause erosive bone disease, so there is no permanent deformity or irreversible deformity as we see previously in patients with rheumatoid arthritis. But because of the course of disease that is get worse from time to time and get arthritis, there will be tendon lesion, and the tendon get lax, which may cause reversible joint deformity that we call it Charcot arthropathy. Renal involvement is one of the main determinants of the prognosis, and it's one of the main causes of death in patients with SLE, especially in the first decade after the disease diagnosis. How patients with renal disease present? They present usually with spectrum of disease that started from asymptomatic, nephritis, nephrotic, or end-stage kidney disease. Then cardiovascular, which occur in 40% of the patients, presented commonly as pericarditis, but can also complicate myocarditis or even endocarditis. Some patients presented with pancreatitis and heart failure. This is about acute manifestation of cardiovascular system. In long-term follow-up of patients with SLE, as we say, SLE is a chronic inflammatory condition. So there will be a progressive atherosclerotic change that could lead to cardiovascular disease and ischemic heart disease later on, which is overall the most common cause of death in patients with SLE is cardiovascular causes. Then pulmonary manifestation, which as for cardiac, which present as cirrhosis pericarditis, and pulmonary present as cirrhosis pleurisy, pleuritic chest pain plus minus pleural effusion. But there are other manifestations like pneumonitis, atelectasis, or fibrosis, and the patient will get chronic breathlessness. Also, there is an increased risk of thromboembolysis in this patient, either because SLE itself or because superadded antiphospholipid antibody syndrome, which we will talk about it later on. Neurologically, the most common neurological manifestation in SLE is headache. But what is more dangerous is the acute presentation of seizure and psychosis. These about central manifestation. Peripheral nervous system, could be involved in patients with SLE as peripheral neuropathy, which occur in up to 14% of patients. Hematological manifestation. Patient could be presented with leukopenia, anemia, or thrombocytopenia. All of them is due to antibody-mediated destruction of peripheral blood cells. What is important is the degree of cytopenia is good guide for disease activity. I mean, the lower the cell, the more disease is poor prognosis or more active disease. GIT manifestation. Some patients complaining of abdominal pain, which could be due to serositis, I mean peritoneal inflammation, or due to vasculitis with involvement of the mesenteric vessel, which lead to inflammation in the wall, edema, and partial or complete occlusion of mesenteric vessel that lead to ischemic bowel. Hepatitis is a recognized complication or maybe added autoimmune disease. Overlap syndrome, I mean. Lab. So, patient presented to us with a suspicion for SLE. What investigation could help us in the diagnosis? We start with simple investigation like complete blood count. We could find leukopenia or lymphopenia. We could find anemia, hemolytic anemia, or thrombocytopenia. During disease activity, there will be raised ESR, but seroactive protein should always be normal. Patient with SLE who has raised seroactive protein, this means he has underlying infection. Finally, autoimmune screening or antibody profile. Majority of patients, more than 95% of patients, will have anti-nuclear antibody positive, which is the most sensitive antibody, but is not so specific for SLE because many diseases can cause anti-nuclear antibody positive. So it is the most sensitive, but not the most specific. The most specific test, the most specific antibody is anti-Smith antibody, followed by antibody to double-strand DNA. From these three antibodies, anti-double-strand DNA have relation to disease activity, meaning the higher the titer of anti-double-strand DNA, the more active disease, while the other two antibody does not. There is no single investigation or lab that could diagnose SLE. The diagnosis is by criteria. We have a lot of signs and symptoms. We need to collect 4 out of 17 to diagnose this patient has SLE. These 4 could be collected at the time of diagnosis, or some of them could be get by previous history of patient with SLE, as we see later. Now, the criteria, as we mentioned, it is 17 criteria divided into 2 categories. 11 clinical criteria, 6 immunological criteria. So, when we say the patient has to have 4 criteria, at least one of them from different group, meaning either 3 criteria from clinical, 1 criteria of immunological, or the reverse is true. Clinical criteria. Number 1, let's start with mucocutaneous criteria. First, acute cutaneous rash. We previously mentioned 2 types of acute cutaneous rash. One of them is malar rash. Second is the photosensitive rash. Any one of them, we score 1. Chronic cutaneous rash, previously discussed, and we name it discoid rash. Oral or nasal ulcers, because it is painless, so many patients does not report this ulcer. So in each patient in which we suspect SLE, we should actively look for ulcer because it's painless. Number 4, non-scarring alopecia, which is generalized alopecia. 5. Arthritis, which should be non-erosive, involving 2 or more peripheral joints, and characterized by tenderness, swelling, and or effusion. Serositis means inflammation of serosal surface, either pericarditis or pleurisy. Renal criteria, we have to have either proteinuria more than 500 mg per 24 hour or cellular cast, RBC cast. Any one of them we give renal 1 point. Neurological manifestation, either seizure or psychosis. Hemolytic anemia, score 1. Leukopenia, meaning white BC count below 4,000 or lymphocyte counts below 1,000. Both of them we give leukopenia 1, either white BC count below 4,000 or lymphocyte count below 1,000. Finally, thrombocytopenia below 100,000 is positive criteria. Autoantibody, any antibody from the list positive, we score 1. Anti-nuclear, anti-double-strand DNA, anti-Smith antibody, anti-phospholipid antibody, low complement level C3, C4, or direct home test positive. Thank you very much.